students. So today we will be continuing our series of labor room lectures for the channel OBGYN Decoded. Today let's talk about induction of labor. So what is induction? What is augmentation? These are two terms which you have to clearly separate. So induction is when you are artificially making the onset of labor through some medications or by some mechanical methods. Whereas augmentation is when labor has started spontaneously and you are increasing the frequency of contractions using some medications. So these are the two terms which you have to clearly define. Regarding the indications for induction of labor is on the rise nowadays because of various maternal and fetal comorbidities which are being increasingly diagnosed and high risk pregnancies which are on the rise. So almost 10% of labor is being induced nowadays. So coming to the indications. So indications, we can have maternal and fetal indications. So one most important is the post-dated pregnancy or a post-term pregnancy. So post-dated is when she has crossed 40 weeks of gestation. Post-term is when she has crossed 42 weeks of gestation. We generally don't wait for a post-term pregnancy. In India, the routine is once she crosses her EDD, we induce labor. So Indian guidelines, according to Indian guidelines, we don't go post-dated. Beyond 40 weeks, all patients we generally induce. Some American and UK guidelines, RCOG guidelines may suggest waiting up to 42 weeks with careful monitoring, and beyond 42 weeks, it calls for induction. Next most important is the maternal comorbidities like gestational hypertension, preeclampsia. So whenever we have a preeclampsia with severe features, we don't wait beyond 34 weeks. Preeclampsia without severe features, 37 is the cutoff to terminate. Same way for diabetes. Gestational diabetes on insulin, 38 weeks is the cutoff. Gestational diabetes on medical nutrition therapy, we wait up to 40 weeks with careful monitoring. RH isoimmunized pregnancies, again 37 to 38 weeks or earlier depending on the fetal condition. If she has premature rupture of membranes, then in case of a premature rupture of membranes, we can wait for 24 to 48 hours for spontaneous labor to set in. But most of the cases, we don't wait up to 48 hours. If labor doesn't set in very soon, then we plan for induction in order to reduce the incidence of complications like postpartum sepsis, early neonatal sepsis and all these conditions. Coming to the fetal indications, most important is fetal growth restriction, oligohydramnios, and any uteroplacental insufficiencies. So these are the conditions where we will decide and individualize the time of termination depending on the severity of the growth restriction or the uteroplacental insufficiency. Next, coming to the methods of induction. How do you want to induce labor? So most commonly we have either the pharmacological methods and the mechanical methods. So pharmacological methods, we have prostaglandins and oxytocin. So most commonly used prostaglandin is the prostaglandin E2 or the dinoprostone and prostaglandin E1 or misoprostol. Now how to decide which method to prefer? So first of all, you have to assess the patient, rule out any contraindications like CPD, cephalopelvic disproportion, any contracted pelvis, any fetal distress. If there is severe uteroplacental insufficiency, severe fetal growth restriction, maybe I will not induce that patient. I would rather go in for a cesarean section. Then very early preterm, again, I may not induce. So depending on the patient and if there is any previous history of classical cesarean section, previous one lower segment cesarean section, yes, you can induce, you can allow for a VBAC. But previous classical section, previous hysterotomy, if there is any invasive cervical carcinoma, there is a lower segment tumor, lower segment fibroid, placenta previa, malpresentations, all these are contraindications for induction of labor. So first of all, assess whether the patient can be induced. Second, look at the pelvis. Do a clinical pelvimetry to ensure that the pelvis is adequate. Then look at the Bishop's score. So Bishop's score is the most important pre-induction scoring which will help you to decide what method of induction to follow. So Bishop's score has 5 components. You have the cervical dilatation, effacement, the position of the cervix, the station of the fetal head are the most important components. So you have a scoring from 0 to 3 for each component and the maximum score which we can get is 13. So any score above 6 is considered as a favorable Bishop score. Anything less than 6 is a non-favorable score. So whenever the Bishop score is favorable, if it is more than 6, then we can go in with methods like Oxytocin, which will act faster. Whereas if the Bishop score is poor, then you need to ripen the cervix. In such case, you will either choose a dinoprostone gel or probably a misoprostol. So PGE1 will cause more effacement. It will cause the cervix to soften faster. Whereas dinoprostone will also help in ripening of the cervix. So both of these can be used interchangeably. Some people, they have their own preferences. So now even mifepristone is being used for ripening of the cervix. So we can use either mifepristone and then followed by dinoprostone or misoprostol, or we can directly go with a gel or a misoprostol. So dinoprostone gel is available as a gel form. It can be used either intracervically or in intravaginally, and we also have an insert, vaginal insert, which is available. So that can also be used, and that will cause slow release of the dinoprostol. Misoprostol is available in a tablet form. So for induction of labor, we use either 25 to 50 micrograms of misoprostol, not more than that. We can use it orally, sublingually or vaginally. So depending on the route where we are using, we repeat the dose every 4 to 6 hours, maximum up to 24 hours. So 3 to 4 doses we consider with one method, and if she is not responding to one method, then probably we will have to switch over to another method of induction. Coming to the mechanical methods, you can either do what we call is the sweeping and stretching of the membranes. So by stripping the membranes or sweep and stretch of the membranes, we are going to cause artificial release. We are going to just cause the release of prostaglandins. As the membranes are separating from the cervical wall, it will cause natural release of prostaglandins, and it will help the patient to go into labor. Similar mechanism, what we use is when we use a Foley's catheter for induction. So Foley's catheter, we are going to introduce it into the extra amniotic space. So between the membranes and the uterine wall, we are going to insert the Foley's catheter. So through the cervix, we are not going to just keep it in the cervical canal or at the level of the internal os. It is going to go into the uterine cavity. And then once we distend the bulb, we are going to inflate around the bulb with 50 or 60 ml of saline. You can also instill normal saline between the layers, between the uterine wall and the amniotic membranes, or you can just put in a Foley's catheter, inflate the bulb and let the bulb rest on top of the internal os and tape it to the maternal thigh. So that is again going to cause slow prostaglandin release, as well as it is going to help in the dilatation of the cervix. So Foley's catheter, generally once we introduce, we leave it in place for 12 to 24 hours. Some people leave it in place till it falls, but usually after 12 hours, some people after 24 hours, if it doesn't fall off spontaneously, then we remove it and then we reassess and we go in for some other method of induction. Coming to oxytocin. Oxytocin is used when there is a favorable Bishop score, more than 6. So oxytocin, we can start with low doses and slowly increase the dose over a period of every 30 minutes. So as we slowly increase the oxytocin dose, the contractions are increasing. You have to monitor the contractions, you have to monitor the fetal heart rate every 30 minutes, and then slowly increase the oxytocin dose. So different guidelines have different dosages, low dose, high dose regimes are available. So depending on the patient condition, you can choose either a low dose or a higher dose oxytocin. And especially if you want to avoid fluid overload, then you would go in for a higher dose concentrated oxytocin drip, where you reduce the amount of fluid in which you are infusing it. And strictly, it is better always to give oxytocin with an infusion pump rather than manually counting the drops. That is about oxytocin. And the last method is the artificial rupture of membranes. Again, for artificial rupture of membranes, it is always advisable she should be at least 3 centimeters dilated. If you are going to do an artificial rupture very early, then probably sometimes the amniotic fluid will all drain out and she might go in for a dry labor. There might be a prolonged labor leading to chances of infection. So usually ARM as a method of induction is not very popular, but yes, definitely as a method of augmentation, it is a very popular method. So it should be done under strict aseptic precautions, and at least you should see to it that the fetal head is engaged, it is well applied. Otherwise, cord prolapse can occur when you are doing an artificial rupture of membranes, especially if the head is high up. So always look for cord prolapse. You check once you are doing a vaginal examination, you have done an artificial rupture, keep your hand for some time, let the fluid drain out slowly, and see to it that the head is fixed in the pelvis. Also, watch if there is any cord coming out immediately. Put her on continuous fetal monitoring after you have done an artificial rupture of membranes. So always ARM should be done with due diligence and due care, maintaining asepsis, and always look for cord prolapse once you have done an ARM. So this is regarding the methods of induction of labor. Next, coming to the what is called as failed induction. So there are different guidelines. Some say 2 methods of induction, some say 1 method of induction using maximum dosage. So generally once we induce labor, we don't go beyond 24 hours. So failed induction is that she has not gone into active labor. It does not tell you whether she has delivered vaginally or she has delivered by cesarean section or she has not yet delivered. It is that she has not gone into active labor or at least 3 to 4 centimeters dilatation by using 1 or 2 methods of induction with their maximum dosage. So even the old teaching says you should not let the sun set on a laboring woman twice. So within 24 hours, once you have started induction, you see to it that within 24, maximum 48 hours she delivers. So for that she should go into active labor by the end of 24 hours of induction. So that is called as failed induction. Next, coming to the complications of induction. So complications may vary depending on the method you are using, but generally most important complications, one is failed induction. There are increased rates of cesarean section. So increased rates of cesarean section may be because the induction has not worked, it has failed. Second, she has gone in for hyperstimulation, fetal distress, increased passage of meconium, increased incidence of meconium stain glycer. Now meconium stain glycer per se is not an indication, but if it is associated with fetal bradycardia, then definitely yes, it is an indication for cesarean section. Then coming to rupture uterus. Rupture uterus, although we are not seeing nowadays too many cases, but still yes, there are incidences of rupture reported, especially if she is a grand multi, if she has a previous cesarean section or hyperstimulation has gone unnoticed, then in these cases rupture uterus can also occur. So you have to be very careful when you are inducing, monitor the patient properly, don't allow her to go in for hyperstimulation, be careful with the Bishop's score, and depending on the Bishops you take the call whether to give the second dose of induction or not. Then after rupture uterus, the next most important thing you have to worry about is incoordinate uterine action. So sometimes they will hyperstimulate, sometimes there may be incoordinate uterine action, there might be prolonged labor. So again, depending on the method of induction, you can switch over to oxytocin here to try and augment the labor if there is incoordinate uterine action. There may be a delay in descent, there may be a delay in dilatation. So if you have not assessed CPD properly, probably there might be a delay in descent. So again, plot the WHO labor care guide once she starts going into active labor. Watch for smooth progress of labor. Again, incidences of postpartum hemorrhage are also higher in patients whom you have induced labor. And if you are using oxytocin for a very long time, it may lead to water retention, it may lead to water intoxication. So these are all the complications of induction. So finally, the take-home message is you assess CPD, assess the Bishop's score, and then decide regarding the method of induction. Both prostaglandins and oxytocin work well. Prostaglandins are more for ripening of the cervix. Oxytocin is more for dilatation and augmentation of labor. You can use mechanical methods with safety under aseptic precautions. Foley's catheter is probably one of the best ways where it will simulate the natural labor. It will be a slow progression and it will simulate the prostaglandin release in the way the natural spontaneous onset of labor sets in. So thank you, and if there are any doubts, please write it in the comments section. Do like and subscribe this video and follow the channel OBGYN Decoded.